So is this okay? Can everybody see my screen?
Yes, Datin.
Yes, Datin.
All right. Thank you. Assalamualaikum and good morning, everyone. Thank you for joining me this morning to listen to what I have prepared. I think I'm kind of like a bit excited to share with you this little project, which I've been working on it for quite some time already, and I must say that I would like to thank Prof. Ida Hilmi from UMMC, who actually mooted the idea of coming up with the IBD reporting guide to help us pathologists in reporting IBD with more confidence. I would also like to thank Dr. Nick Razima, also an gastroenterologist in Sly Hospital, for giving some input for the clinical section of this, the clinical form in section A. And also thank you to IAPMD for sharing this platform for me to share this reporting guide, which this is actually a preliminary viewing, I would say, because we don't know whether it works or not. I will try to go through the guide and see, and later maybe we can try out, we will select a few centers. We'll see whether it works or not. Okay, so my presentation is in the Word form because I wanted to make a slides, PowerPoint slides, but I thought I would miss some important stuff. I wanted to show the whole document so that you can actually understand what I'm trying to come up with. Okay, so basically, this reporting guide consists of 3 sections. The first section, section A, is for endoscopists use, the clinical information form. Section B is for our use, the pathologist use, where we will give our histologic summary. And then the third section is on the notes on histologic features of IBD as well as other differentials, and also what is expected of the histologic description and information that is expected from us to be given in the reports. So the aim of this guide is, or as the name says, it's supposed to be a guide to guide us in endoscopic biopsy assessment of colonic and sometimes small bowel mucosa, and for hopefully we'll be able to come to a conclusive interpretation of the biopsy, be it in the first time diagnosis of IBD or cases of known IBD cases of follow-up, what information to give so that the information that you provide is useful for clinicians in following up their patients. And also to look for also as well as suggest other possible non-IBD underlying etiology, whether if it's not a case of IBD, then what else could it be? Or if it is an IBD case, you may have secondary pathology taking place as well, giving the resulting in a worse clinical presentation in such patients. And also the notes also highlight some the changes that may be confused between IBD and some non-IBD colitis. Okay, and hopefully this guide also will improve communication between clinicians and us in terms of relevant clinical information that they need to provide in specimen submission, as well as on our part to improve our histologic description and interpretation. So as I said just now that this document is just a prelim. I envision a trial run perhaps between July and August for about 4 to 6 weeks. We will decide on the number of cases. But it definitely needs cooperation from both clinicians and pathologists, and because we need feedback from both parties and to see whether this guideline is not guide. I mean, it's guide. This reporting guide is useful or not. So next, we will go to the first section, which is the form that the clinicians need to provide with the specimens. We go through the forms, both forms first, before we go through the notes. Okay, so the clinicians need to tell us whether this is a new case, a known case of IBD or not known, and what were they presenting symptoms of the current clinical episode, needing them to do the biopsy. If there is diarrhea, they need to detail out whether it's what sort of diarrhea, is it watery or mucus, and if there is blood, whether any other associated complaints such as abdominal pain, anemia. Sometimes patients may just present with weight loss and perianal discharge, not so much of bowel symptoms, other bowel symptoms. And so they need to tell us all that. Okay, and then we need to know the duration, definitely, because when they say chronic diarrhea, how long is it? 2 weeks is chronic to me, so it's very subjective when you say chronic. So they need to tell us whether, how many days, how many weeks, how many months, because sometimes sometimes we receive specimens from inmates who have diarrhea for a week, but they get colonoscoped because of the situation that they being inmates, sometimes they do the scope rather fast. So so it's a short duration of a presentation, so we need to know that. Okay, so that will assist us in the interpretation. Now, they have to tell us the endoscopic findings, the procedure that they did, and extent of intubation. And they need to tell us the appearance of the mucosa. For example, that if there is ulceration, what type of ulceration is it? Whether it's fissuring type, or there is cobblestone, or whether there is diffuse ulceration and inflammation. So they need to write that down. And they will have to tell us the sites that are involved, whether it's whether it's pancolitis, entire bowel is involved, or certain parts of the bowel is involved. So all they need to do is just tick for the sites that are involved and tell us whether it's focal or segmental or continuous, or there's discontinuous or skid lesions, or there's pancolitis. Sometimes patients get to have OGDS as well at the same sitting. They need to inform us the findings as well. Sometimes, or maybe it's been done earlier, so it doesn't matter. Sometimes they also have, they get enteroscopy, small bowel enteroscopy done. If that is so, then also we would like to know what's the finding, so they need to scribble that down. Okay, so in section number 3.4, let us know if there's any suspicious for dysplasia or neoplasia. And anything else that they want to tell us, they can write in other comments. And they will have to identify the sites that are being biopsied. Every segment need to be submitted in a separate containers, so that we can give a more meaningful interpretation. This will all be covered in our notes, in the discussion on in the notes later. So also, if they have any information on radiological information or relevant lab investigations, such as stool culture, C. diff toxin, CRP, fecal calprotectin, usually done for patients who are suspect to have IBD. Any other relevant clinical history, such as family history of TB, any drug use, whether patient, if it's a case of IBD, whether on treatment or defaulted treatment, that sort of things. And we would like to know what are their thoughts in a sense of clinically, if they're thinking of IBD or otherwise. So It's quite simple. According to Razima, this form is simple to use. So we hope that if it is really, we get to use it, that they will, the clinicians, the endoscopists will provide us all this information. Now we go to section B, which is for us, the pathologists. So this is how it looks like. I just compress it in one page for the purpose of this presentation, but later if we get to use it, I will make more space for you to have space for to scribble stuff. You know, this is a checklist or a histologic summary. It's not meant to entirely replace your routine narrative reporting. But later, if you get to use this form, if you decide that it is for use, then you may, you can discuss with your clinical colleagues whether you want to let them have this copy as well, in addition to your narrative reporting. But the idea of this form is actually for you to fill up once you have completed your histologic assessment and you have to come to a certain conclusion in the findings. Thus, you will see the stuff that you need to record here, not in the order of, probably not in the order of your thoughts, because when you do your histology assessment, obviously you will, what you notice first is whether there is inflammation, whether there is architectural distortion, but that is a bit afterwards. What the first thing that we want you to record is whether the distribution of the changes that you see overall once you have completed your assessment, whether the changes are focal or patchy or diffuse, and involved sites, you just tick whichever the sites that are involved, depending on the specimens that are being submitted. And if you're not able to comment on the distribution, just like this, let them know why you're not able to. Sometimes all the biopsy from all segments are being put in one container, so there's no way of us telling the distribution pattern of the so-called disease that's affecting the patient. Now, the second point is regarding the features of chronicity. Basically, when we say chronicity, it means we are referring to chronic inflammatory cells, mucosal architectural distortion, plantar cell metaplasia, and pseudopilaric metaplasia. These are the main things that we look for. There are things that I will cover in the notes section later. So we know that chronic inflammatory cells are normal constituents of mucosal lamina propria. So you have to sort of like minus out the normal component for the lamina propria, the amount of cells that are supposedly to be normally present in the lamina propria of the bowel mucosa, and you decide whether there is any increase or not. If there's no increase, just take no. Otherwise, you just say whether it's mild, moderate, or marked. It's kind of subjective, but I always say that you always compare with, keep some slides of normal, keep some normal slides of bowel mucosa or resection specimens, bowel resection specimens close by, so that you can always go back and refer to. You have one of right side and one of left side, so that you can compare objectively. And whether there is basal plasmacytosis, and you note whether it's mild or moderate or none at all, and whether there is architectural distortion, which can be in the form of creep architecture, branching, or villiform change, irregularity. So that is also kind of subjective, but as you go along, you see some pictures, you may decide, whether it's mild, moderate, or marked. Okay, so plantar cell metaplasia, whether it's present or not, or pseudopilaric metaplasia is present or not, we'll go through in the notes later. Now, mucosal activity, whether if it's present, and just note whether you see ulceration, erosion, cryptitis, or crypt abscess, inflammatory and neutrophils in the surface epithelium, or at least whether there is a neutrophils present in the lamina propria. And again, you just try to classify whether the activity is mild, moderate, or severe. Again, we'll cover that in the note section later. If you see granulomas, please describe the granuloma or make notes, take note of whether they are, the size of the granulomas, small or micro or large or medium size, whether caseous necrosis present, whether it's coalesced or non-coalesced, whether they are easily seen or occasionally seen, the sites, whether it's the superficial mucosa or deeper mucosa or submucosa, and whether they are present in normal looking or non-inflamed areas, endoscopically normal looking areas or non-inflamed areas. Okay, so section 5, any other histologic changes which is covered together with the non-IBD histology case, non-IBD cases, which I will cover in note 5. And in note 6, if you have decided that it's a case of IBD or you think it's IBD, then you try to say whether it's UC or whether it's definite or likely or favoring UC over CD, or whether it's a case of possibly likely Crohn's disease, or if not, you feel that it's likely CD over UC, and maybe you make some comments. Or if you're not able to do so, but you think it is IBD, but it's hard to tell whether it's UC or CD, you're not able to decide at all, then you may call it IBDU for a temporary diagnosis, or until you have more information, or maybe sometimes the sampling is not adequate, and until you have a proper sampling done, then the case may be classified as IBDU at that point. Okay, so now we go to the details of the notes. So regarding a distribution of changes, now, it is very important for us to know the sites that are being biopsied so that we know where are the sites, the segments that are involved, be it inflammation or any changes at all present in the mucosa, and so that we can decide whether if patient has such changes, whether it's a left-sided disease or whether it's a right-sided disease, or whether it's pan-colonic involvement, whether there is ileal disease confined to ileum, terminal ileum, or there is ileal involvement in together with the involvement of other parts of the colon, whether there is rectal sparing, and whether the disease is diffuse or continuous versus focal, patchy, segmental, or discontinuous colitis. Okay, in the case of chronic IBD, knowing the sites that are being biopsied and distribution pattern is very important for the reasons that are highlighted down here in one section in point 1.2. If you're seeing a right-sided disease or more intense changes on the right side of colon compared to the left side, then it's likely it's a case of Crohn's disease. If you see patchy or discontinuous or segmental colitis, it's also more likely to be Crohn's disease. If you see diffuse and continuous inflammation or more severe changes in distal colon as compared to the proximal part, then you're likely dealing with ulcerative colitis. If it's a case of pancolitis, pancolitis most likely is UC. But if there is ileal inflammation at the same time, this probably represents backwash ileitis. Caveat to this statement is that sometimes I've seen a few cases of Crohn's disease, but to the colonoscopist it looked like as if it's pancolitis, making a clinical impression or giving a clinical impression of ulcerative colitis, but it's actually a case of Crohn's disease with superimposed acute inflammation. So the appearance is that on clinically, on scope, it looks like pancolitis, but in histology, it will not be so. It would be looking more like Crohn's disease with features supported by histologic changes that I will show later. Now, the next point is if you see patchy, segmental, or discontinuous colitis with associated ileal inflammation, then it's likely Crohn's disease. If it's pancolitis with ileal involvement, it's probably backwash uveitis. But otherwise, if it's patchy with ileal involvement, it's likely CD. Okay, so the next point is if you are dealing with a known case of ulcerative colitis and you see rectal sparing, so it's probably related to topical or suppository treatment that patient's getting. The next point, important point to remember is that in long-standing ulcerative colitis, whether patient is on treatment or without treatment, the mucosa changes can be patchy or discontinuous, looking much like Crohn's disease. That is why it's very, very important for the clinicians to be telling us the duration of symptoms patient having. Because I've come across one case many years back, never presented with a small bowel carcinoma. For the first time, had a small bowel resection for the cancer, and the background mucosa showed changes of Crohn's disease, classical Crohn's disease. So really, like our people, our population, sometimes they can be, they can stand all those, the pain until like towards the end, until they develop cancer to that extent. So again, you have to, take things really comprehensively, whatever the information that is given, provided to you. Now, talking about a distribution of changes, this histology of 2 cases of ulcerative colitis. These pictures are trying to show that in the case of ulcerative colitis, this is typically what it does. It causes diffuse inflammation involving all fragments. If you're talking about within the same segment, all the fragments are equally involved, equal intensity of inflammation. These are 2 different cases showing same kind of changes, and also including the architectural changes. So it's a diffuse within the same area. The inflammation or the changes in the mucosa is diffuse, involving all fragments equally. In contrast, in the case of Crohn's disease, you'll see involvement of the mucosa within the same area. There will be intra and inter-area variation. Within the same area or intra-area variation, it can involve different fragments as well as within the same fragments. So these 3 pictures showing you involvement of the variation in involvement of different fragments. See, this mucosa is very inflamed, or in the sense that there's significant increase in chronic inflammatory cells and architectural distortion. This fragment looks very normal. This one is subtle increase in chronic inflammatory cells for this fragment, and the next 6 to 8, the fragment actually looks very normal. So this is a mucosa in Crohn's disease, where you see variation within the same fragment. Some areas look quite dark and some areas look quite light in color. So intra-area variation, the involvement, intra-area variation can be between different fragments as well as within the same fragments. Now, the next point that we need to take into account is the features of chronicity. So we need to tell, these are the information that we need to provide. So we look at the notes on features of chronicity. So as I said earlier, main features of chronicity are represented by increase in chronic inflammatory cells with basal plasmacytosis, sometimes with or without basal plasmacytosis, mucosal architectural distortion, panacea metaplasia, and pseudopyloric metaplasia. These are the main chronicity changes that you'll be able to see in most cases of IBD. Right. So, but before we can appreciate what's abnormal, for those who have attended so many of my lectures before, I will never fail to highlight the importance of appreciating normal colonic mucosa. So, you must be able to appreciate, the normal tubular crypt architecture. with the creep bases touching the muscularis mucosae. Sometimes you have a bit of shearing artifact because of the procedure, the pulling artifact. So you have to see a slight angulation of the crypts that is acceptable. That is the shape of the crypts, but on cross section they look nicely tubular and evenly spaced. And with regards to the inflammatory cells, the distribution is the normal inflammatory gradient or plasma cell gradient or lymphoplasma cell gradient is predominantly in upper third of the mucosa. The lower third looks relatively empty. So in IBD, in chronic IBD, you tend to lose this gradient. Okay. And also for in terms of the inflammatory cells, inflammatory infiltrate, in addition to lymphoplasmacytic cells, there will be eosinophils and macrophages present. Neutrophils are not normal, so you're not supposed to see neutrophils. Okay, so if you see neutrophils, you have to decide whether that is significant or not. If you see one neutrophil is probably and nothing else, and not, I mean, just one neutrophil in one fragment is probably because of the procedure related. It's not really insignificant inflammation. But the other thing I want to highlight is that eosinophils tends to be more present, and they are normally present in the mucosa and tends to be more in right side of colon, cecum and right side of colon, ascending colon, and reduce towards the distally. Okay. So next is on chronic inflammation. So when in case of chronic IBD, you will see usually transmucosal increase in chronic inflammatory cells, and sometimes with vasoplasmacytosis. These are objective markers of chronic inflammatory bowel disease. Vasoplasmacytosis, in addition, is the earliest diagnostic feature with highest predictive value for ulcerative colitis. So if you're able to identify vasoplasmacytosis, you can be quite suggest a possibility of IBD, even if the clinical presentation is not that straightforward, like short history, for example. Okay, so the other thing is when you have when that is sometimes in early stage of UC, the crypt architecture and also the inflammatory cells, the chronic inflammatory cells are not that overtly increased. So much so that you don't observe the transmucosal increase in chronic inflammatory cells. But if the clinical history is suggestive, you may want to recommend for the clinicians to repeat the biopsy no sooner than 6 weeks for a more definitive assessment. Hopefully, it will, after 6 weeks, that it will prevail. Because the close differential for these kind of changes would be prolonged infective colitis. So you would expect with treatment, the infective colitis will resolve, but IBD will persist, and probably more the changes will be more enhanced. Right. So this is what I'm trying. This figures 2.4, 2.5 showing what is transmucosal increase in chronic inflammatory cells. This is transmucosal. The middle part of the inflammatory of the lamina propria is filled with lymphoplasmatic cells. The amount is similar to the small superficial part. And then there is separation of base of the crypt from muscularis mucosa. That is vasoplasmacytosis. And vasoplasmacytosis is also can be represented by basal lymphoid aggregates, such as in this figure 2.4. Okay. I'll just wait for the noise disturbance to clear up. I think Faizatul Arbaya, I think you got to do something about the noise. Okay. Next is on the mucosal architectural distortion. We're still talking about chronicity change. The mucosal architectural distortion is represented by variable degree of crypt architectural branching, or dilatation, or as well as distribution, irregular distribution. And sometimes, not uncommonly, you will see in colon, you see villiform surface change, okay, such as this. So these are figure 2.8 and 2.9 are from colon, that they look more like ideal mucosa, okay. On contrary, these are 2.10 and 2.11 figures of actually terminal idiom, showing irregular villi with blunting and bulbous looking villi in 2 cases of a suspected Crohn's disease. Right, so what are other changes of indicating chronic mucosal injury or chronicity change? As I mentioned, Panna cell metaplasia. We say Panna cell metaplasia when you see Panna cells in left side of colon, because Panna cells are normal constituents of small bowel mucosa, and also you can see small amount present in right side of colon, cecum, and right side of colon up till transverse colon, but they are not normal in descending colon and rectum. Caveat to this is that if you're dealing with pediatric cases, in children, in young children, you can see Panna cell metaplasia.
Datin, can you unmute yourself?
Yes, I have, right. It's okay, right. Okay, now, so other chronicity changes, so I just continue on the Panna cell metaplasia in children, especially younger children. You will sometimes you can see occasional Panna cells in left side of colon and rectum. So finding Panna cell metaplasia in children, you have to take it with a pinch of salt. You really have to, make sure other changes of chronicity change are present before you call it IBD. Having said that, also sometimes children present with chronic constipation, and Panna cell metaplasia tend to be a lot in chronic constipation in children, but not in adults. Okay, so just take note on that. Okay, next is pseudopyloric, just the pictures of Panna cell metaplasia, looking just like what you see in small bowel, but this is actually from colon, the pictures from colon. In the case of UC, okay, for Panna cell metaplasia, you can see both in UC and Crohn's disease, but more commonly in UC. Now, pseudopyloric metaplasia is actually when you see glands that looking like pyloric glands on the stomach, or in the stomach, or Brunner's glands in the duodenum. You can see them anywhere throughout from small bowel to rectum, but they are actually a form of reparative metaplasia. Usually develop or appear in the setting of chronic ulceration. Usually, most commonly you see in Crohn's disease, but you can also see in chronic ischemia as well. Although ulcerative colitis is also a chronic ulcerating disease, but somehow in UC, I don't remember seeing pseudopyloric metaplasia in a UC case. So it's usually in Crohn's disease. If you're dealing with IBD, it's usually in Crohn's disease. So this is pseudopyloric glands, looking like what you see in the pylorus of the stomach, what it looks like in the ileum of a patient with Crohn's disease. Now, next is features of chronicity. Again, hypertrophy of muscularis mucosae and neuronal hyperplasia, something which you may not be really looking for, but if it's present, it's worth it to mention and like help you in supporting your findings. So if provided that the mucosa is well orientated, then the thick muscularis mucosae and thickened and splayed and abnormal looking muscularis mucosae can be taken as a feature of chronicity. So you can see here the mucus is well orientated in figure 2.16, and you can see very thick and splayed and abnormal looking muscularis mucosae. In the next, the picture next to it is showing neuronal hyperplasia. Normally, you don't see nerve bundles, but you can see here, you see neuronal hyperplasia, nerve bundles in the submucosa on the, sometimes in ulcer-based tissue. So if you see these two findings, they are more supportive for Crohn's disease. Now, however, I just want to give a note of caution. Sometimes you can see features of chronicity in non-IBD cases where there is a chronic mucosal injury, such as as I mentioned earlier, in bowel ischemia. Also, sometimes you can see in mucosal prolapse syndrome, in association with diverticular disease in the mucosa around the diverticuli, and also sometimes in NSAID-induced injury. So again, the scope findings and the history is very important. The clinical history presentation is very important. Okay, so now we go back to the form. Our next thing is on the discussion is on mucosal activity. We're supposed to be telling what sort of mucosal activity changes that we are seeing, as well as the severity. Okay, so go back to note 3. Note 3 on, okay, so as I said earlier, neutrophils are not normal to the colonic mucosa or ileal mucosa or bowel mucosa anywhere, and any of the bowel, any part of the bowel mucosa. So if you see, you have to decide whether it's significant or not. Like I said earlier, if you just see, a trickle or rare neutrophils, it could be just related to due to a procedure or bowel preparation. Otherwise, we will see whether we will decide whether the neutrophils are present just within the lamina propria or infiltrate the epithelium of the surface of those of the crypts, or whether some inflammation or some inflammatory cells are present in the crypt lumen, so that we have crypt abscess. Generally, we do not score the degree of activity unless, except in research settings. I've been asked by clinicians regarding this. I say we do not do it routinely. I mean, I don't do it unless in the research settings. But it's highly recommended that we grade in the sense of the severity, at least, whether it's mild, moderate, or severe, to help to stratify patients that at risk for cancer. I mean, to patients into risk categories, whether be it for cancer screening, as well as to determine the completeness of remission following treatment. Okay, so basically, when you see ulceration or multiple foci of erosions, you can call it marked, at least moderate, if not marked. If it's very focal ulceration, it can still be moderate. If you see ulceration everywhere in tandem with what the clinicians see in the scope during colonoscopy, then it will be, supportive for marked activity. So the intensity of the activity is increased with the presence of, multiple cryptitis and crypt abscesses. Okay, so as well as erosions and ulceration. So these are some pictures in figures 3.1, 3.2 until 3.4. You see ulceration here, and erosions, surface erosions, and cryptitis, with neutrophils within crypt epithelium, neutrophils within the lamina propria, and then there are two crypt abscesses here. Now let's go back to our form. So now, if we see granuloma, we have to, spend some time to appreciate the characteristics of the granuloma, because it will be helpful in deciding whether we are dealing with Crohn's disease or TB, or like a possibility of other causes. So go back to the granuloma story. Okay, so granulomas can be due to infective or non-infective causes. But in our daily practice, when we come across granulomas in the mucosal biopsy of the mucosal biopsies, the first thing that we will be thinking of either is Crohn's disease or of intestinal tuberculosis. And often it's not easy to decide because the granuloma characteristics are kind of like borderline between the two conditions. But if we try to make a point in try to stratify which are pointing towards which CD or TB, sometimes we'll be able to, in correlation with the clinical presentation and the scope findings, we may be able to suggest the possibility of the underlying cause for the granuloma. Okay, so generally, granulomas that are large, coalesced with with caseous necrosis, many granulomas per biopsy area, and those that are present in deeper part of the mucosa or submucosa are supportive for TB. On the other hand, if you see microgranulomas or poorly formed granulomas, no caseous necrosis, non-coalesced, mainly in superficial mucosa, and if you see very few occasional ones, and they're more suggestive of Crohn's disease. Okay, so but interpretation of granuloma when deciding whether it's TB or non-TB or TB or Crohn's disease has to be made in correlation with the findings with the other parts of the bowel that are biopsied. Okay, so when you say microgranuloma, what do you mean by microgranulomas? Usually it's about the size of 1 to 2 crick diameter. So these are pictures of microgranulomas. The size of just slightly larger than 1 crick diameter. This is about the size of 2 crick diameter. They're quite poorly formed, sometimes easily missed on low power microscopy. Okay, so I just want to highlight that in infective causes, you also have other causes of other non-infective causes of granulomas other than TB. So just be careful. But usually these infections will be supported by findings in microbiological culture, so thus it is important to have some information on that. Okay, so before that, I'll just show you of course, these are classical TB granulomas. So many of them, many granulomas coalesce, caseous necrosis deep in the submucosa. So this is classical TB. You say this, you have no problem at all. You will diagnose TB with a blink of an eye. But there would be times when you see intermediate sized granulomas, some present in the mucosa, some in the submucosa, a few in number, but no microgranulomas, just intermediate sized granulomas. So these are the cases that can be difficult for you to be certain that you're dealing with Crohn's disease or TB. So I have prepared here a table to try to characterize between the granulomas that are found in Crohn's disease and intestinal tuberculosis. So these are the features that I have mentioned earlier. A highlight to this is just in addition to the size and the formation, I want to mention that microgranulomas you don't see. Well, you don't usually see in intestinal tuberculosis. You only see in Crohn's disease. If you think it's microgranuloma, just make more levels to make sure that you are really dealing with microgranulomas. After a few sections, the microgranulomas will disappear. If it's a TB granulomas, the microgranuloma which appear initially will become larger. Okay, so that is one. Okay, the other thing is I want to highlight on the presence of lymphoid coughing, which is I think a useful feature. In TB granulomas, you have prominent lymphoid cough, but in Crohn's, you don't have that much of lymphoid coughing. Okay. Now, lymphoid hyperplasia around the TB also, sorry, the granulomas also would be more suggestive of TB. Okay, and very useful change finding in support of your to decide whether the granuloma is that of TB or Crohn's is the finding of granulomas, especially microgranulomas in areas where endoscopically is non-inflamed or not affected. So if you find granulomas in endoscopically normal-looking segments, it's a kind of like bullseye finding for Crohn's disease. Okay. Of course, if you find cobblestoning mucosa and perianal disease, probably more supportive for Crohn's disease, but this is actually the clinicians will have to tell you all these findings, even not this not on histology. Okay, so all right, so later, I mean, you can see this this table, you can scrutinize this table later. Right, so go back to other histologic changes. We go back to our form. Other histologic changes basically to cater for if you have decided that it's non-IBD, whether you can decide, you can give a diagnosis of some sort of diagnosis which you think it's not IBD. So we go to the what's there in note 5. All right, so the most important thing to exclude is if to come to conclusion whether this could be a case of a prolonged diarrhea because of prolonged acute infection or prolonged acute infective type colitis. Okay, so basically, we want to diagnose infective colitis is by the absence of chronicity changes. Okay, but a caveat to this is that in Crohn's disease, sometimes you can have very little change in chronicity change, or sometimes you don't see the areas that are being biopsied do not show increase in chronic inflammatory cells of significant mucosal architectural distortion, and with no granuloma. So you will be looking like almost like infective type colitis. So if the history is that of 6 months diarrhea and you're seeing features of looking like infective colitis, likely it's Crohn's disease rather than prolonged infective colitis. Okay. The other caveat is that sometimes in infective type colitis, prolonged infection, like you're talking about, sometimes people can, go on and on having diarrhea for 6 weeks, 8 weeks. Sometimes there will be slight mucosal architectural change in the form of mild irregularity. Also, there will be mild increase in chronic inflammatory cells, not amounting to forming basal plasmacytosis. So that also can cause some confusion with chronic IBD in like prolonged. Occasionally, the prolonged infective colitis can cause mild changes of chronicity. So the next table is showing you how to differentiate between infectious colitis and IBD.
Oh, yes, I knew what happened. What happened to her? She's an idiot,
Okay, so back to our table. So as I said just now, deciding whether infectious colitis in most instances is by absence of chronicity change. Okay, so infectious colitis, you have neutrophil infiltrate, cryptitis, crypt abscess. Some in prolonged infection, you have a weak increase in lymphoplasmacytosis, or towards the resolving phase. You can have this. But otherwise, you shouldn't be seeing basal plasmacytosis. You shouldn't be seeing significant crypt distortion, surface form change. You shouldn't be seeing parathyroid metaplasia or pseudopyloric metaplasia or glandular atrophy. Okay, in IBD, you see all this. So if you see cryptitis and crypt abscess, it doesn't change. It doesn't tell you the difference. You gotta look for chronicity change. And of course, granulomas, if you see, it will be pointing towards CD. Caveat to this is that if you see pericryptal mucin-related granuloma, then it could be ulcerative colitis still. So when you see ruptured crypt, some mucus in the lamina propria, and you see granuloma formation, if it's mucin granuloma, is not to be interpreted as true granuloma. Okay, so look for really juicy non-mucin related granulomas for you to decide whether it's Crohn's disease or or you see. Now, next is, all right, so there are so many other causes of diarrhea or bowel PR bleed, or sometimes, you know, like weight loss for that matter. So sometimes patients, I thought that the easiest way for me to highlight the possible underlying etiology other than IBD is by showing you cases. So I've got a few cases here just to highlight the possibility of findings in your biopsy. If it's not IBD, what could it be? So for case number 1, there's a case of a female with 3 months history of chronic diarrhea, but she was recently diagnosed with retroviral disease. And on low power, it looks like, on low power, it looks like infective colitis, NOS, but always spend extra time in cases of retroviral disease to make sure that you don't miss any organism. Like opportunistic organisms especially, and like in this case, you see tiny organisms on the surface epithelium as well as the crypt epithelium, as those are of a cryptosporidian species. In the case of cryptosporidiosis in a HIV patient. Okay, so in the diagnosis of retroviral disease, if not provided, may cause you to give cause you to go through very fast, giving a diagnosis of infective colitis and then NOS, whereas you could give a more definite interpretation, if you spend a little bit more time. Always look on the surface epithelium. Case number 2 is one who presented with clinical history of very suggestive of IBD, which this case I presented in a few years back in IAPMD meeting. There's some on low power, you see architectural distortion, some patchy increase in chronic inflammatory cells, but in some areas you see this very classical ischemic changes. So chronic ischemia can mimic IBD, can mimic Crohn's disease. But if you see this kind of changes with necrosis in the upper half of the mucosa thickness with mucus and inflammatory debris on the surface, sometimes you can see highline change of the lamina propria. So think of ischemic colitis rather than IBD, because this case was misdiagnosed as IBD and did not respond to treatment, and following which the review actually showed chronic ischemia changes, this ischemia was confirmed by when they did CT mesenteric angiography and showed thrombosis in the some vessels in the abdomen. Now, case number 3 is about microgranuloma story. Of course, when you see microgranulomas in the superficial surface epithelium, the first thing you will think of is Crohn's disease. And Crohn's disease, as I mentioned, may not give much of chronicity change. Architecture is quite preserved, just mild increase in chronic inflammatory cells. With microgranulomas like this, and with history of chronic diarrhea, and in this case, the patient actually presented with enterocutaneous fistula following appendectomy, on further scrutinizing the biopsy, there was this abnormal amyloid deposition in some vessels. A review of the appendix also showed similar changes, but with more chronicity changes, including architectural change of the mucosa with fissuring ulcers, microgranulomas, as well as amyloid deposition in the vessels. So it's a case of Crohn's disease, also again missed. But in addition to the Crohn's disease diagnosis, you find amyloid. So amyloid deposition can be primary or secondary. And secondary amyloid deposition can occur in many conditions. One of it is chronic inflammation of any cause, So in this case, I feel that there is a possibility that the amyloidosis is secondary to Crohn's disease itself. But of course, the clinicians need to verify on that, and they will need to do other investigations, relevant investigations to confirm that this is actually a secondary amyloidosis rather than primary. Okay, the next case is case number 4. Zara, how I am doing with time? Am I okay? Zara?
I think actually we are going to be, I think, about 50 minutes now. I guess we can go until 1 hour. That would be like another 2 to 3 minutes more.
Oh, okay. All right. So because we have some questions. Okay, so I
we
think
have some question, but we can I mean the session will be up to 12 o'clock. I guess it should be okay then.
Okay. So I have about 15 minutes. I have about 10 minutes, 15 minutes. I think I can do it.
15,
Yeah, so all right. So the next case is of a 26-year-old male with a history of chronic constipation for 7 years and recently developed prolonged diarrhea of 6 weeks duration, and scope showed patchy colitis with ulcerations or side of colon and some inflammation of terminal ileum. And the low power view showed intact crypt architecture with not much of increase in chronic inflammatory cells, but you see intense staining in the submucosa and mucosa, and on high power you see dense eosinophils within the lamina propria as well as some infiltrating the crypts. Eosinophils, normal eosinophils are normal in the bowel mucosa, more so in right side of colon and cecum. But you should not be exceeding like 40 per high power field. Some people take it lower value, like more 30, or some people actually take a cutoff point of 20. But I generally take a cutoff point of 40, especially in our setting. We consume a lot of exotic food, you see, in this part of the world. So we probably have more eosinophils than other parts of the world. So anyway, so this is an awfully lots of eosinophils in the lamina propria of this patient. So an additional history shows that this patient actually has marked peripheral eosinophilia, 69% out of 39.6 total white cell count. So that is an awfully high peripheral blood eosinophilia. So it is possible that this is a case of eosinophilic enterocolitis, but the diagnosis has to be a clinical one, meaning they have to make sure that there's no other cause for peripheral eosinophilia. Eosinophilia is that it can be it can occur in relation to malignancy, that sort of things, so they really have to, the clinical people need to verify that there's nothing else causing the eosinophilia, and then we can safely call this eosinophilic enterocolitis. And the presentation of chronic diarrhea, chronic constipation is actually quite suggestive as well. If eosinophils is predominantly affecting the outer layers of the bowel wall, then patients tend to present more chronic constipation. Okay, next case number 5 is a 53-year-old female complaint of watery diarrhea of 3 weeks duration. Architecture looks okay, no, maybe on low power, not that obvious, but maybe this is a biopsy of the rectum with probably, if any, would be very mild, very subtle increasing by inflammatory cells. Otherwise, not that obvious from this magnification. Anyway, there is thickening of the subepithelial collagen plate, but it looks quite focal. They biopsied a few areas, but only the rectum showing the change. So sometimes it's always sometimes it can be quite confusing whether the so-called thickened subepithelial collagen plate could be due to tangential cut. This is not tangential cut because you can see the nucleus of the surface epithelium is nicely aligned, single layered, not pseudostratified. Okay, so single layered, nicely aligned nuclei of the surface epithelium. This is significantly thickened collagen plate. So with the finding of the history of watery diarrhea, and she was also found to have diverticular disease, but otherwise no significant findings. So we can safely suggest that this could be collagenous colitis or microscopic colitis. But the thing is that the important thing to note is that collagenous colitis or be it lymphocytic colitis can be patchy. It may not involve all parts of the bowel segments. In fact, in the same segment, it may not be present in the entire segment. So multiple bowels is important. So kind of lucky for this patient, the clinicians happen to biopsy those affected areas. Last case, just to highlight double pathology again. This is a 16-year-old girl presented with chronic diarrhea of 4 months duration with significant weight loss of 15 kilos. Scope showed terminal ileitis, and at the same time there was also inflammation in the rectum with superficial ulcers. So the upper 3 pictures are those of the terminal ileum. I've shown the middle picture before, showing these blunted barbels looking villi, shortened villi. This does not, if you don't know that this is from terminal ileum, you may, from low power, you may not recognize that it's actually terminal ileum. There's a significant increase in chronic inflammatory cells with significant architectural distortion. There is activity, we can see cryptitis here. So looking like active chronic ileitis of some sort, granulomas. But the rectum mucosa showed quite straightforward changes of solitary rectal ulcer syndrome. Very prominent fibrosis of the lamina propria, splayed prominent smooth muscle cells, within the lamina propria as a distorted muscularis mucosa layer of the smooth muscle of the muscularis mucosae. And in some areas you can see surface erosions. Yeah, and then hyalinized lamina propria. Again, sometimes in the areas of surface erosion, there can be accompanying in neutrophils and a granulation tissue like appearance of the lamina propria. So this is a case of I call this. I mean, I told the clinicians this. We're probably dealing with Crohn's disease, looking at the chronicity change in the terminal ileum, but at the same time, the solitary rectal ulcer is a second pathology, which upon further questioning by the clinicians, the patients do admit of having, doing digital evacuation of fecal evacuation. So the history is kind of suggestive, supportive for that. Okay, so that's on the other possible pathology other than IBD that you may come across in your daily routine microscopy diagnosis of the colonic mucosa or bowel mucosa. So back to go back to our form, the last part of the form. So now after summarizing everything that we have found on histology, so we need to decide, are we dealing with IBD or not? If it's not IBD, so we have gone through in note 5, possibility of finding one of these. Most often is the infective type colitis, but beware, you may find also GITB, also quite common, and other SRES or mucosal prolapse syndrome is also kind of common in daily practice. Okay, so if you think it's IBD, try to decide whether UC or CD, or if you can't decide, then tell why you can't decide. Sometimes you're not able to decide. You cannot able to decide whether it's IBD or not IBD for certain reasons. In the case of granulomatous colitis with borderline features of TB and IBD and Crohn's disease, you just can't tell the difference. So you just have to admit. So you just have to, do further correlation, wait for more information on the lab test and all that. Just convey your uncertainty to clinicians, okay? Also, the uncertainty also sometimes because in the case of active colitis, very subtle chronicity changes, whether it's prolonged infection or whether it's a early phase of IBD. That is also something that we know is you really have to buy some time to make a more conclusive interpretation. So we go to note 6. In note 6, I just table out if you think it's UC, if you think it's IBD, try to decide whether it's UC or Crohn's disease. These are the in the interest of time. I mean, these are the usual, as you've seen in my lectures before, the features that will differentiate or helpful to differentiate in differentiating between UC and Crohn's disease. Okay, I think highlight to it is actually between whether it's a diffuse inflammation or whether it's patchy inflammation, whether granulomas are present. Panel cell metaplasia points more towards of Crohn's disease. Pyloric gland metaplasia, pyloric gland metaplasia points more towards Crohn's disease. Panel cell metaplasia you will see in both, but more commonly in UC. Neuronal hyperplasia and muscular mucosal hypertrophy, you will be pointing more towards Crohn's disease. You can look at all these findings and details in this table later. Now, just to cover for completion, the term indeterminate colitis and unclassified colitis, IB indeterminate colitis and IBD unclassified. You use them when you're not able to differentiate between Crohn's disease and UC. We know it looks like IBD, but you can't really tell which one is it, you know. Sometimes because of insufficient clinical information, or maybe the sampling is inadequate. Sometimes they do localized sampling, you know. So, or sometimes there are overlapping features between Crohn's disease and ulcerative colitis. I've seen a case with, you know, diffuse inflammation, pancolitis, but there is hardly any mucosal architectural change in the mucosa, which is not typical of ulcerative colitis. Usually you will see significant mucosal architectural change. But in this particular case, the crypt looks so good, so nice, but with diffuse increase in chronic inflammatory cells. So it's kind of like very mind-boggling. Like I can't really decide whether, you know, really it's a UCD or UC case. A note to this indeterminate and unclassified colitis is that you use the term indeterminate colitis for resection specimens. Okay, for IBDU you can use for mucosal biopsies when you see overlapping features or clear features that are not so clear, that you're not able to decide at that point. But maybe later on repeat biopsy or more clinical information, then you may be able to do so. Okay, so it's a kind of like a temporary diagnosis until more information or more features are more available or more obvious. Okay. So I have additional notes on UC and CD, including those on page. So these ones you can read yourself later. But I must say that this document will not be available for everybody's use yet at this point. I will, with discussion with the clinical sites, where we will decide whether we can, that on the centers that want to participate in the trial use of this reporting guide, and then see if it's useful or if there is any changes that need to be made or to improve, then before we kind of like adopt it, if the gastro and the pathology sites are agreeable to this document. Again, so I come to the end of my presentation. Again, I would like to thank Prof. Ida, being the person who mooted this idea, and on behalf of IBD Special Interest Group, IBD SIG. I think without that, I think I did. Even though I sat on this project for so long, but the fact that I think I feel that I have to do it. I have to get it ready. For those of you who are not, who are still not in the know, I am going to be retired in November. So I hope that this project can be completed by October, including the decision whether we will be able to use this document as a standard in our daily routine practice. Okay, thank you very much for your time. I'm sorry if I've taken extra time, but I thought I have to make it things make it clear to everyone of what needs to be known in IBD diagnosis. Thank you.
Thank you, Datin. We have, a lot of questions here. I guess I shall read one by one. We'll start with a question, not a question, questions from Dr. Salamia Azman for Datin. If there is only increased neutrophil in the lamina propria without cryptitis or crypt abscess, is it mild activity? That's question number one. Number two is
can I answer one by one? So
definitely, yes.
Yeah, okay, for that question, yes. If you refer to some papers, I think one of it is actually the British reporting guideline. They want to see neutrophils in the epithelium to call it activity. But my experience is that I do call it mild activity in when I see neutrophils in the lamina propria, even if I don't see in the epithelium, because the sampling could be an issue. I mean, sometimes you have a limited sampling of a small amount of tissue being sampled. Also, sometimes when you do levels, you will see, occasional neutrophils in the epithelium or the surface epithelium. I still, personally, I do call it mild activity if it's an inflammatory neutrophils only in the lamina propria. Yes.
Okay. Question number two. What about eosinophilic cryptitis, which does not fulfill the criteria of eosinophilic colitis? Would it be considered as activity?
No. Eosinophils in the crypt epithelium, a few occasional here and there is normal. If you see nothing else, just a lot of eosinophils in the lamina propria, way beyond 40 per high power field, you may want to make you may want to make a morphologic diagnosis of mucosal eosinophilia, because the underlying cause for mucosal eosinophilia is a lot. So I mean, a few I can name is actually, you can see in IBD, you can see in helminthic infestations, drug-induced. You can see in, of course, eosinophilic colitis is is a diagnosis by exclusion. So I usually give a morphologic diagnosis of mucosal eosinophilia and give a list of differentials. If I see nothing else, but if I see features of chronic IBD, then eosinophils is just part of IBD changes likely. Seeing eosinophils in the epithelium in the case of IBD, it's not considered as activity. So you don't base your activity on finding eosinophils in the epithelium. I rarely describe eosinophilic cryptitis unless I want to highlight in eosinophilic a case of eosinophilic suspicious eosinophilic colitis, when there is really prominent eosinophilic cryptitis and crypt abscesses. Otherwise, if it's present in the setting of IBD, then I don't really bother to describe, and I don't interpret it as activity, but it is considered as clinically. You see that is as a kind of like activity kind of finding, but not to be graded and not to be interpreted on histology as part of degree of activity. I hope I make sense.
Okay, next question from Dr. Suguna. Datin, I recently came across a small superficial located microgranuloma associated with IEL and crypt abscess apoptosis. Can it be associated with drug-induced colitis, or we still need to entertain Crohn's?
That is very, very interesting. I wanted to show cases with increased crypt-based apoptosis, because increased crypt-based apoptosis also has a few differentials which you need to take note. I will include later in the document, because I didn't have time for that. Increased crypt-based apoptosis, you can see it in several conditions. In IBD, definitely. You can see it in HIV infection. You can see in CMV infection. You can see in graft versus host disease. You can see in drug-induced colitis. Sometimes occasional crypt-based apoptosis also you can see as a result of bowel preparation. So really you have to see, you have to interpret crypt-based apoptosis together with other histologic findings and also the clinical history. Microgranuloma, seeing microgranuloma in the subepithelial or the superficial mucosa is something which should, like make you think of Crohn's disease first, so because of course in drug-induced colitis, you can have sometimes pattern of granulomatous pattern of drug-induced colitis is possible, but always drug-induced pathology is by exclusion. I mean, if you see the history of drug use is only from the clinicians. We have no, we cannot confirm on that. So it's by exclusion. If you feel worried, you just mention it in your comment. But you're saying crypt-based apoptosis, superficial microgranuloma, and I think you mentioned cryptitis. Cryptitis?
No, IEL.
Intraepithelial lymphocytes, yes. Increased intraepithelial lymphocytes also, you can see it in Crohn's disease, in inflammatory bowel disease. So yes, that would be, again, if you don't see significant architectural dysfunction, you see these three features, I think you can still suggest the possibility. In lymphocytic colitis or microscopic colitis, increased intraepithelial lymphocytes should be together with increased lamina propria chronic inflammatory cells, and you shouldn't be seeing granulomas. So that should rule out microscopic colitis or lymphocytic colitis. So again, drug-induced colitis is diagnosed by clinical exclusion. If the history is such, the clinicians are suspecting IBD and you're seeing these features, likely it is Crohn's disease.
Okay, next question from Dr. Irene. Would you recommend a certain number of levels before we would satisfactorily conclude the absence of microgranulomas in a suspected Crohn's disease cases?
Yeah, this is kind of like a tricky question. There's no right or wrong to it. But how I do stuff in my lab is that the initial section, the technicians will do a serial, one slide serial, and from there on, I will decide whether I want to do how many levels after that. So, I mean, there's one recent case, Malini from Klang is now doing attachment with me. She saw a case with, some features suggestive of Crohn's disease, but not really straightforward. But the case was later on sent to Alostar for review, and I don't know how many multiple levels after that, then there were granulomas present. So there's no right or wrong to it, but I would say, I think 3 levels in 3 slides at least. If you're thinking of Crohn's disease, I think would be I'd say acceptable for if you think that's but if you still, because you're not, because in IBD, in colonoscopic biopsy, you're not talking about one slide. You have sometimes 6 segments being biopsied, and you want to do 3 for all segments. Kind of like can be quite tedious for you to go through every level, but I would say 3 is kind of acceptable. 3 slides or few levels on one slide as a guide, I think.
Right. The next question is from Dr. Su Anida. What's the best way to differentiate conventional crypt abscess, apoptotic crypt abscess, and immune therapy as in anti-PD-1 related colitis?
Excuse me. Can you repeat the question, please?
Okay. What's the best way to differentiate between conventional crypt abscess, apoptotic crypt abscess, and immune therapy related colitis, as in anti-PD-1?
Okay. Crypt apoptosis. You're seeing more of crypt. You're saying crypt apoptosis or crypt apoptotic abscess and
Apoptotic crypt abscess, the
Uh-huh.
conventional crypt abscess.
Okay. Yeah. So the apoptotic crypt abscess, you say as the crypt abscess, the conventional crypt abscess would be, you see neutrophils live and healthy. You know, you can make out the shapes of the neutrophils with cytoplasm and you know the multilobated nuclei. But in apoptotic crypt abscess or apoptotic bodies or apoptotic crypt abscess, it's just very intense dots of degenerated nuclei with intense eosinophilic cytoplasmic remnants, if you like. Yeah, but no, you don't see a nice formation of neutrophils as in the crypt abscess. In immunotherapy, or in some immunodrugs therapy, yeah, you can see a lot of crypt apoptosis in the setting of this. In that setting, when you see a lot, you may not see much. Just increase in crypt apoptosis or crypt apoptotic abscess. The other thing that the main differential you want to exclude is because the patient is immunocompromised in that sense, is to exclude CMV infection. That's a very important differential. So of course, look for the inclusions and do your CMV immunostain. But in immunotherapy, I mean, the history would be suggestive or supportive of the possibility of the changes due to immunotherapy.
The next question is from Dr. Nazifa. Is it common for IBD to involve the appendix?
Okay, appendix it's not really common, but I've seen occasionally. I mean, one case that I showed just now of Crohn's disease affecting the appendix. I didn't show the picture of the appendix, but the one with amyloid, there was obvious involvement of the appendix, which I did not include in the pictures. But it can be involved, but unless we are given the samples of the appendix, that we will not know. But I do see on and off appendiceal involvement, mainly in Crohn's disease.
Right. This is from Dr. Suguna again. Do we need to do CMV antigen IHC in a persistent active disease despite on treatment, or in superimposed acute colitis picture in IBD cases, even though we don't see inclusion on HNE?
Yes, I kind of like quite routinely do CMV immunostain for IBD cases on treatment, but with persistent inflammation or not responding, or suddenly develop flares. You do want to exclude concomitant superimposed CMV infection. I would say that the final the decision to accept it as a superimposed CMV infection, or rather that either that or it's just a bystander when you see it's positive, would also I would say requires clinicians input. They may want to do CMV IgM for confirmation. Usually when I've had cases where I see juicy CMV inclusions, but the patient seems to be responding well to treatment for IBD alone, not given any treatment for CMV, but inflammation resolved. So even if you see juicy CMV inclusions, it may not necessarily be a concomitant or superimposed infection, but you may suggest as a cautionary note, and the clinicians need to do some correlation. I do routinely do CMV immunostains for those kind of cases, yes. But give a cautionary note, whatever your findings is.
Next question from Dr. Fazila Hassan. What is the most distinctive pattern in SRUS versus UC, as both can share similar features in biopsy?
SRUS and UC, the similar findings, the plus point as in the similar findings for both the two conditions, actually more of there'll be ulceration on scope and ulceration in histology, and there'll be architectural distortion, creep irregularity mainly, not so much of, you can have subtle biliform change as well in the mucosa prolapse or SRUS. But in SRUS, you don't see increase in chronic inflammatory cells. You don't see basal plasmacytosis. You can see the inflammation in SRUS usually, the acute inflammation in SRUS usually related to areas of erosions or ulcerations. In that area where there is surface erosions, so you have a bit of granulation tissue like appearance and neutrophilic infiltration. But away from that, usually you don't see much of activity. The other thing is that going more towards SRUS is that in UC, you don't see mucosal fibrosis. That's the kind that you see. Those mucosal fibrosis with smooth muscle cell hyperplasia extending into the lamina propria, it's not for UC, it's only for SRUS.
Okay.
And also, also some like other chronicity changes like the panel cell metaplasia, that kind of thing. Okay, thanks.
Okay. Next question from Dr. Nur Hidayati. If there is only thin and incomplete subepithelial collagen, is it still favor collagenous colitis?
Thin and incomplete. I don't know how to interpret that, but deciding whether it's truly thickened, you must make sure that the orientation of the surface epithelium is correct. It's really perpendicular, single cell layer, it's not tangential, and there's no retraction artifact of the subepithelial lamina propria. The orientation of tissue is very, very important. And if you're not, sometimes even in normal, well-oriented specimens, sometimes the subepithelial collagen plate can look a little bit prominent. In uncertain, when I'm not so certain, I actually do measure, because normal thickness of the subepithelial collagen plate is about 8 to 10 micron, which is about the size of the red blood cell. And if you have microscope, you have your microscope that you can measure, then you can just measure for certain. If you're not, if it's like borderline, maybe like 15 or slightly more than that of a red blood cell, you may want to make a cautionary note. But I don't make a diagnosis of collagenous colitis unless it's very obvious. Like the case that I showed, even though it was patchy, focal, but the thickening was very obvious.
Okay. Our second last question from Dr. Siti Zarkah. Salam Datin, do we need to routinely do pus and back end stains for all suspected cases of IBD?
For IBD, no, I don't. No. I mean, I do pass ZN if I see if I see intermediate size or large granulomas of intermediate size granulomas. If I see just microgranulomas, that I feel that it is the case of Crohn's disease, rare microgranulomas, other changes of chronicity I do see as well. So I don't do ZN pass. If I see for intermediate size granulomas where I'm not so certain whether this could be IBD or Crohn's disease or TB, I do, yes. In cases where you see only ulceration, no granulomas, but ulceration, when clinically there is I mean, they are clinically and endoscopically, they're also thinking of either CD or TB. That I may do as well, even if I don't see granuloma, but not routinely in the situation. What is the clinical scenario like? If in the case of looking like clear cut, you see, then I don't bother.
Okay, our last question from Dr. Gan. What is the youngest age cut off for SRUS as compared to ulcerated and inflamed juvenile polyp?
Oh, youngest age. Okay, the thing is, I don't think I will base it on age, because I've seen it quite. I think perhaps the youngest patient I've seen is about the age of 4 or 5 years old for SRUS. But the histology of SRUS and juvenile polyps are quite different. It's basically histology, not on the age. So the histology is just different. So the age, I mean, personally, there are not many that I come across pediatric SRUS. A handful, but I've seen probably youngest, if I can remember correctly, about age 4 or 5 years old. Yeah.
All right. Well, that's conclude all our questions. Thank you, Datin, Dr. Nick, once again for this very, I would say for me, it would be like that enlightenment for me as well. It's enlightening me.
Sorry, Zara, if I can just, I'm not sure whether Prof. Ida is with us or not. Maybe if she is around, if she is with us, maybe she can give some comment on the clinical input of for this document. Is Prof. Ida with us?
Yes, Prof. Ida, you can unmute.
Okay, it's okay, Zara. I mean, like you can, you can proceed with the next agenda. Yeah.
I think we can conclude our session today.